great colleague to touch base with whenever there's anything complicated, Dr. Elias Wehbi. Welcome.
Thank you. So happy to be here with you.
Well, I can't wait to get to the meat of the conversation, but I do want to let people know about your background and how they can find you. Dr. Wehbi is local at all of the main pediatric hospitals. That's Miller's Children's Hospital, Chalk, and UCI. There he works as a pediatric urologist, and his interest includes complex reconstruction. My patients know him because he's been found to be the most accessible and caring doctor in the field that I have been having the pleasure to work with. So we became close through my constant contact and nudging him and bugging him. So thank you for always being available.
Always happy to be.
And that seems to be sincere. So I'm going to put a link. You guys can find the link to find out his amazing awards and background and training at the University of Toronto. But we're going to just dive right into our topics today. And we're going to start out with the most common question, learning about the causes of urinary tract infections in pediatrics and when do they need to be seen by a urologist?
Great. First of all, just a couple words. Thank you so much for having me. It's really an honor to be here. I really value our relationship, but more friendship. And I know you provide, the best care for the patients really in the county. And I'm so happy to participate with you in taking care of them. I mean that sincerely. It really is a pleasure to be with you. And I think a lot of the topics we're going to try to hit are hopefully going to be high yield topics for everybody. And really one of the most common ones that we see in the office that can be very confusing across the board is really urinary tract infections. And it's really interesting to see the different practice patterns and how people approach urinary tract infections. I'm going to give you the approach from the pediatric urologist based in best practices and current evidence. And so I hope that's okay. The most important thing with a urinary tract infection is to really understand if it truly is a urinary tract infection. And so there are lots of different presentations that children may have. And we're obviously going to focus on children because I'm a pediatric urologist, and that's where we see most of the urinary tract infections. Typically, children, if they're not verbal and they can't describe symptoms, they're non-expressive, as in babies, they just tend to present sick. So either they'll have a fever or they present unwell, something off of baseline. And it's really important to understand what other causes can have fevers, can lead to fevers, or it can lead to your child being irritable or unwell. And so it's important to rule out other causes, things like upper respiratory tract infections, GI, gastrointestinal infections, common things like ear infections, all those things, viruses that could potentially cause those fevers and your child being unwell. And so the reason we start off that way is because the only way to really confirm a urinary tract infection in a non-toilet trained, non-verbal child who can't urinate voluntarily is with a catheter. Now, I know that's pretty invasive and sometimes hard to stomach. So you don't necessarily need to start with a catheter. You can start off with a bagged specimen. Now, a bagged specimen is only helpful if it's negative. So I'll give you an example just to share something personal. One of my kids had a fever, was unwell. We could not explain it. To save my daughter a catheter, we did a bagged specimen. The bagged specimen was negative. With a negative bagged specimen, you could confidently say that this is very unlikely a urinary tract infection because it's so prone to contamination that if it is in fact negative, it's unlikely to be a urinary tract infection. So that's a good way to start in the pediatrician's office or even in the pediatric urologist's office to just understand that a negative bagged specimen is helpful. But I tell my parents and I tell my pediatricians, I never like to hear that we had a positive urine infection from a bagged specimen. So if you have a child that can't urinate voluntarily on their own and give you what we like to call a midstream urine, then you need to confirm with a catheter. So there's a good chance of ruling out an infection with a bagged specimen. But beyond that, if the bagged specimen is positive, and that should be sent for something called a urinalysis, and then obviously a urine culture. Those are two separate tests. And both of them have to be positive to rule in a urinary tract infection. So you could potentially save a catheter in a non-toilet trained child. What if your child is toilet trained? What do you do? Well, if it's a young girl, then it's simple. She just needs to provide us with a midstream urine. Now, we don't want the beginning of the urinary stream because oftentimes that can be colonized as well. There's always bacteria in that part of the body we call the perineum, the part between the bum hole, like the poop hole, the anus, and the urethra. And so there's normal bacteria there, and oftentimes that can colonize urine specimens. So we never want that initial little bit. We just want the middle part of the stream. And that also should be sent for a urinalysis, the urine culture. Now, what happens if it's a boy? Same thing, midstream urine. The only confounder is if the boy is uncircumcised. If the boy is uncircumcised and the foreskin is covering the head of the penis and you cannot retract the foreskin, then that's also unreliable. You need to be able to retract the foreskin gently, never force it, and then capture a midstream urine after you gently wipe the head of the penis, or in a young girl who's toilet trained as well, midstream urine. If it's a non-circumcised male, which is totally fine, and oftentimes we can't retract the foreskin, which is normal in the first few years of life, then that also needs to be with a catheter if a bagged specimen is positive. Does that make sense?
Yes, this is very useful for me.
Yeah.
I've spoken to you about my patients that I'm sending you, and you'll repeat to me, you need to get a cath. And I just
it's so hard.
I ignore you because of my experiences. I'm telling you, I mean, the parents will come back with a gun. They're going to be so mad.
Listen,
I did it for the first couple of years, and nobody else is doing it out in the pediatric practices. So I finally caved and just did the bags. But now your explanation is super useful, and there are doctors who watch the show. So I think we understand your logic here, that negative.
It's not my logic. This is like best practices. I actually
yes.
I write a chapter. I write the chapter in this book called Avery's Diseases of the Newborn, and there's a whole chapter on urinary tract infections in young children. And I write that chapter every edition. And these are best practices. And so it just stems back to the age-old adage, kind of garbage in, garbage out. If I get bad information, I give you bad advice. And I only like to give good advice. And so the best advice I can glean is really from an appropriately collected urine specimen for the right reasons. And I say the right reasons is because you really need to rule out some of those issues, because nobody wants to avoid catheterizing the child more than me. That's the truth, you know. And and the reality of it is you can do that oftentimes. So some places have like just knee-jerk, kid comes in with a fever, they swab, they look, they test, they put a catheter in. And that's really not the approach, because you should really proceed from high-yield physical exam maneuvers based on history, right? So, I mean, if a kid comes in a home that has had rhinovirus going around like wildfire, and they come in with a fever and they haven't really started with upper tract symptoms yet, it may be okay to hold off on the catheter at the beginning or start with a bagged specimen, for example. Like it's really a combination of, and I know we don't have time, we see lots of kids and we're just trying to take care of people as efficiently as possible. But the reality of it is we do need to provide good care based on best practices. And so you could always start off with a bagged specimen. And if it's negative, it's high yield. But don't go rummaging in the urinary tract unless you think you need to. And that comes with ruling out all those issues first, listening to the chest, looking in ears. Maybe if you have a quick strep swab test in the office, you can do that quickly, that sort of thing. Because a catheter is very invasive, no doubt. And it's very traumatic for parents and for children. But if you came to me, and I see many children in my office, and they come in and the history is multiple recurrent urinary tract infections. And when I spend a little bit of time trying to understand what happened, the tests that were ordered, and the results from which I'm able to evaluate, it's very hard for me to say that this child has actually had clinically significant urinary tract infections. And so that's why it's important to understand why we're doing a test, and to really put some weight on the results. Because if we're ordering tests that we can't trust results for, then I would make the case that we shouldn't be ordering those tests anyway. So In my practice, I never order a test unless I'm prepared to act on the results, or I think it's going to add information. And that goes across the board. It's probably something we're going to talk about a little bit later, a test called VCUGs for when children do have urinary tract infections. We really want to understand when it's indicated to do that specific test, because it's a very invasive test, same thing with a catheter, and it also involves x-rays, which I really want to reduce in my patient population. And it's just not something that I order routinely unless it's indicated or unless I'm prepared to act on the results. I'm expecting something different. Does that make sense?
Yes. But I was also quite relieved to learn more about the digital x-rays, and I'm curious if that's still the situation when you do a KUB to look for, when you do x-rays, we're not talking about massive radiation, correct?
Yeah.
Not what it
Well,
was.
you're absolutely right. So we go by a principle called the lowest allowable dose of radiation, and like the least amount of radiation. It's called this ALARA principle. But even said, you just have to, radiation, it's well described in the literature. It's a lifelong accumulation. So even if you're having low dose imaging regularly over the span of a child's life, that is still a lot of radiation. So I always caution people to really understand why they're ordering a test, especially if it's invasive or it exposes your child to any form of radiation. Always understand why you're doing it, and if you're really prepared to act on the results, and if you're actually expecting to see something. And so it's very important to understand that.
Okay, so that's super helpful for an algorithm for once they're in the office. What would you describe as the main causes of urinary tract infections? And of course, most pediatricians treat one and done, especially around the age when they're wiping themselves. But at what point, there's these rules. If it's a boy at this age, you definitely need to go check things out. Can you explain what you would recommend to parents?
Typically how it works is once you diagnose, so once you think the child has a urinary tract infection, get the right tests, make sure it is a urinary tract infection. And then once it is, appropriately treat it with antibiotics. And then every child that has a clinically significant urinary tract infection, it mandates at least an ultrasound if they haven't had one. So the first thing you want to do is get an ultrasound. And then typically the ultrasound is going to dictate the next step.
So let me interrupt you. You're saying every child with urinary tract infection needs an ultrasound?
I said a clinically significant urinary tract infection requires an ultrasound. So typically a high fever or multiple recurrent urinary tract infections, which have been diagnosed. So not all urinary tract infections are associated with fever. If they have high fevers or the child is unwell, we typically associate this with not just a bladder infection where almost all urinary tract infection starts, but it also may potentially involve the kidneys. So a high fever, a sick child suggests a kidney infection or potentially pyelonephritis, but not always. You can have a fever with just a simple bladder infection that is treated. But if you have a clinically significant event, so a kidney infection or multiple recurrent urinary tract infections, then absolutely you should start off with an ultrasound. It's a very high yield test. If it's normal, it's very reassuring. Right? You can look at, there's a lot of things we look at beyond normal. We look at kidney size. We look at presence or absence of something called hydronephrosis, which is just some dilatation of the part of the kidney in the urinary tract that collects and drains the urine. We look at the ureter tube. We look at the bladder. We can look to see how much stool is in the rectum, which gives us an idea of constipation as an issue, which I'm sure we'll talk about, is very important to understanding and preventing urinary tract infection. So it's a very informative test. And when it's normal, it's very reassuring. If there are abnormalities to it and there are some specific things that we look at, then it helps guide the next step, which may or may not include, the test that we call a voiding cystourethrogram or a VCUG, which is that test I alluded to before where a catheter and some x-rays to help look at the bladder, see how the child voids, evaluate the presence or absence of something called vesicle ureteral reflux, so when urine starts in the bladder and moves back up to the kidneys, and a few other things. We get some x-rays so we can look at the bony skeleton, and there's quite a few, there's much information that we can get from a VCUG, but again, it's invasive and it exposes your child to x-rays.
Okay, so just to summarize, VCUG would be something that after looking at the ultrasound might be indicated, not always after the first criteria are met that we discussed. So I'm taking notes. That's why I'm circling back.
Yes.
I'm putting notes in here. So that a
Yeah,
child with
wonderful.
a fever, like a kidney infection or multiple recurrent infection, needs the ultrasound. From
Needs
there,
at least an ultrasound, correct.
they don't automatically need the VCUG. Would you want a
No.
pediatrician to order a VCUG automatically in some of these scenarios, or contact you?
Yes, if they're comfortable at that point, understanding some of the nuance, which I'm sure they can be, ordering a VCG. So typically, if you see some abnormalities on the ultrasound, things like hydronephrosis or hydroureter, which is a dilated ureter, the tube that connects the kidney down to the bladder. Those are some of the reasons. Sometimes we see other anatomical abnormalities on the ultrasound. So certain things like if we see cysts or rotated kidneys in different locations, sometimes there are some things that we can see where we think that the tube can insert in an abnormal location in the bladder. So the ureter can insert an abnormal location, or there are other types of anomalies where there's a persistent small membrane over the exit site of the ureter into the bladder called a ureteral. So there's a whole list of things that potentially we want to know if there is the presence or absence of reflux, what the bladder looks like, the bladder shape, if there is something called trabeculation, which gives us an idea of how the bladder is cycling and how the bladder is emptying. So there's a long list of things. So if you're comfortable based on the ultrasound, if it's a totally normal ultrasound, the child has had one infection, especially if it's a non-febrile infection, then typically it's okay to hold off on a VCUG. Because most of the time, even if they have something called a reflux or if they have some other issues, you're probably not going to do anything about it. And so why get the VCUG? And it's unlikely that with a completely normal ultrasound, there are going to be very significant findings on a VCUG, although a VCUG and an ultrasound aren't always concordant. So they don't always, so even if there is reflux, for example, it's not always represented well on the ultrasound. So you can have, for example, very bad reflux and a very reassuring ultrasound, or a almost normal ultrasound. They don't always match up, high reflux and a bad ultrasound. So that's why there's quite a bit of nuance to this.
Great. All super useful. I just generally count on you and check in
I'm
with
always
you.
available. That's the
I'm
funny
not sure
part.
if that's what goes on in the real world. So let me ask then, what are the main causes of urinary tract infections?
So the urinary tract infections, like most things, are multifactorial. So it's never just one or two things that are generally responsible for urinary tract infections. It's usually a multifactorial, approach to everything else. So, if you think about it, some children have a slightly higher risk of having a urinary tract infection than other children. And so you could have two kids doing the exact same thing, eating, drinking, behavior is the same. One child gets a urinary tract infection, the other child doesn't. And that's just based on their own inherent biology. So there's different thresholds for each child. And so you could have some children, for example, that don't have good perineal hygiene. So girls that wipe, for example, back to front, or aren't cleaning the perineum well, or are poorly hydrated, or have constipation. They're not cycling the bladder normally. They're holding their stool and they're not stooling regularly, and they're holding their urine and they're not cycling the bladder regularly. You could have two children doing that to varying degrees, and one may get infections and one might not. And that's just based on their inherent risk. So we always approach it in a multi-pronged approach. And we know that constellation of things that we call bladder and bowel dysfunction is extremely important. So it speaks to presence or absence of constipation, presence or absence of holding and delaying urinating. I mean, the body's essentially number one self-defense mechanism is to cycle the bladder normally, to have urine wash the lower urinary tract, and decrease the amount of bacteria that can make its way in and multiply in the bladder to hit that threshold for a urinary tract infection. And bacteria, believe it or not, multiplies very quickly. So some bacteria double every half an hour to an hour. And so if you think about it, the typical thresholds for a urinary tract infection is about 100,000 CFUs, or colony-forming units. So that's that 100,000 that we see on urine studies for most bacteria. And if you think about it, if the bacteria doubles every half an hour to an hour, it only takes about 10 hours, 10 to 11 hours to meet that threshold for a urinary tract infection, which is very short. It's not a long time. And so cycling the bladder normally and washing the lower urinary tract is extremely important, especially in girls, because the urethra, the P tube from the outside of the body to the bladder, is extremely short. It's only a few centimeters. In boys, it's different because it's much longer. The bacteria has to make its way all the way into the bladder, stick to the wall, multiply, do its thing. In girls, it's very short. It's always trying to get in there. And so that's why we see, usually only in the first 6 months to a year of life, the risk of urinary tract infection, especially in uncircumcised boys, is just a little bit higher. But then after that, by far, girls are at risk for having urinary tract infections more commonly. So that cycling of the bladder is just so basic, but extremely important. And so why do we talk about constipation in these kids? We talk about constipation in these kids because the muscles of control for stooling that keep us clean from leaking stool and dry from leaking urine, they're pretty much the same muscles in the pelvic floor, right? So if I put this to our viewers, if you really had to have a bowel movement and you really had to urinate, and I asked you to just have a bowel movement and not urinate, could you do it? And the answer to that question is probably not. If you really have to have a bowel movement and really have to urinate, and I ask you to just have a bowel movement and not urinate, you can't do that because the muscles of control are essentially the same in the pelvic floor. So when children tend to hold and delay stooling, they always tend to hold and delay urinating to some degree, which impacts that bladder's ability to cycle the bladder normally and wash the lower urinary tract thoroughly and decrease the burden. And it's very important. And so that's we always focus on constipation, and then we also focus on bladder health as well. Focusing on one and not the other does not do our children a service. So it's very important to understand that.
Okay, and then is there some thought that there's movement from stasis of the stool across into the bladder, or is that an old thought? Is it more just pelvic floor?
Yeah, so that translocation of bacteria, it's possible. It's been demonstrated in lab studies, and it's something that we may see, but really in practice, bacteria makes its way up through the urethra from the area of the body between the anus, the poop hole, and then the urethra. And then it makes its way up into the urinary tract. And most urinary tract infections start off in the bladder that way. And so, things like hydration and being able to cycle the bladder. So if children are really dehydrated, for example, they don't cycle their bladder because they're not producing enough urine to do it regularly. What also happens is they get constipated, right? What does your body do when you're dehydrated? It concentrates urine and tries to hold on to as much free water as possible. But what it also does is it sucks all the water from the food that you eat and reabsorbs it into the body, especially in the large intestine, and especially near the end as well. So stool gets harder. So when you're dehydrated, you don't just see yellow pee and concentrated pee and not cycle the bladder as normally as you should. It also leads to constipation. So you're not cycling the bladder normally, and then you're leading to that, what we call pelvic floor muscle dysfunction, which basically is that holding and delaying urinating. And you can teach your body to, even when you want to urinate, to not be able to. So I'm sure some of our viewers can relate to this. If you're in your car for a long time and you've been holding it and you really have to urinate and there's no restroom, right? Because you're in the car. You finally get to the restroom. It's not as if you can't urinate or that there's no urine in your bladder. Oftentimes what happens is the bladder gets overdistended, so it can't squeeze as well. But then also what happens is the muscles of control don't relax completely. So some people describe, taking a minute or two to get started to urinate, or that the flow is not as strong, or they might not empty their bladder well. That's part of that pelvic floor muscle dysfunction that we talk about. And that'll happen just like one time if you did that in the car. Imagine like some children, they every time they urinate, they really hold it until they have to go, and then they urinate. Imagine that's how you urinated multiple times a day, multiple days a week for multiple months. You can develop severe pelvic floor muscle dysfunction. So when it comes time to urinate, You don't really urinate well. You don't empty your bladder well. You don't cycle the bladder normally because you're not relaxing those pelvic floor muscles. And we see a lot of children get into trouble that way. Those are the kids that have lots of urinary tract infections and poor bladder and bowel health.
I think that's going to be a big obstacle now that we're going back to normal and people are having their kids back in school. I always have, the preschoolers and kindergartners, elementary school, even, they just feel like the bathroom's dirty, or
Yeah.
you hit a public restroom with a really loud flush and the kid has some PTSD thinking they're going to get eaten by the toilet. So, but these are real
I've heard that as well.
I mean, real problems where they have to work through using external bathrooms outside the house. So this is something that people should think about right now, taking your children out at the park and not being afraid to use the toilets there. Our COVID numbers are coming down so nicely. This good hand washing in a public restroom should be just fine. And we need to get our kids, the whole germ phobia is going to be in the kid's head as they go to school and they don't want to sit on the toilet to stool or use the restroom to urinate. And that's going to be leading to increased holding and this pelvic floor dysfunction. So I'm so glad you brought it up.
Yeah, those are real life problems. And I mean, I think you just hit it on the head. Those are just some of the things that as doctors we don't talk about that can be pretty prohibitive.
And, a lot of kids, one of our listeners is saying that her kids are so afraid to flush. And that's true. So it's, baby steps, even a reward chart for every time they do when you're out and about. What if you need to give any type of reward or sticker chart, that could be a good thing for them, because just like drinking water, excreting it is just as important from what we're hearing today.
Yeah, it's interesting. My wife is a behavioral therapist. And so I incorporate a lot of her recommendations in my practice in these children with, that have some of these issues that are predominantly based in, behavior and, being sensitized in a specific way. And it's been very, very useful to think about it that way, because that just, as physicians, that's not how we're typically, trained. We just, some of it is based in medicine and evidence, but there's a lot of things in just common sense and what actually parents have to deal with on a regular basis that just escape us. And so, that's a very, very good point you made about that, because it's really important to understand what those barriers are, and then really incentivize your child to do what it is that's necessary to help promote good bladder and bowel health and avoid these issues.
And on this point, one of our listeners remarked about their child being afraid to ask for help to open the door to the bathroom, embarrassed. And you have to talk to your kids. So they weren't going to the bathroom at school. You definitely have to talk to your kids about bathroom use at school and what any obstacles or hurdles that need to be overcome. It's so prevalent. I would say one in every family, they're dealing with it. And if a parent doesn't ask, sometimes it's too late. They already have a habit that has formed or a fear that has become real in the child's head. So right now we have limited accessibility to go into the schools. So really be creative about talking to the child or going after school if they might let the parents in to see what the bathroom looks like. And, watching your child use a public restroom or the school restroom is really important, and talking through their fears.
I would agree with that completely. I mean, these are just some basic things that can make a huge impact. Absolutely.
That are just so common.
One of the things that I hear from my parents a lot is hydration, and how trying to keep the kids hydrated, because it really is such a big factor in managing the bladder and bowel issues, because it's so important. And what I always tell them, we give them rough guides of how much kids should be drinking, and typically we'll say an 8-ounce cup per year of life, up to 8. But that's really only a guide. And a good example of why that's just a guide is because it really depends on your requirements. So like if I gave you, for example, a gallon of water to drink, which is a tremendous amount of water, and I gave you a gallon to drink on a Monday, and I gave you a gallon to drink on a Tuesday. And Monday I made you run a marathon in the hot sun, and Tuesday I made you sit at home and just binge watch your favorite show, right? Monday you'd make very little urine, running in the hot sun, long marathon. Tuesday you'd literally pee every 15 minutes. You drank the same amount both days. So the way I kind of guide my parents with that is kind of that rough guide of an 8-ounce cup per year of life, up to 8. But then they really need to titrate the drinking to clear urine, because generally when the urine is clear, typically what that means is they're drinking enough to cycle the bladder normally, and they're drinking enough to keep the poop soft. And it's kind of a good sort of way to do it. The other thing is when you kind of drink the fluid. So like the same amount, I gave you a gallon of drink and I said, drink this in an hour. You'd literally pee every 5 minutes until you were back to normal. And then for the rest of the day, you'd be dehydrated. But if I got you to drink it over the course of the day, same volume, right? Then you'd generally be hydrated over the course of the day. You'd be cycling the bladder normally, and you'd have enough fluid on board to keep the stool soft. And so those are some approaches to hydration that are very important and very basic. And the key thing is really try to incentivize your kids to try and be hydrated. The reality of it is you have to be on top of your kids. Like if you wake up in the morning and you say, okay, make sure you drink your water bottle today and pee every 2 to 3 hours and make sure you have a good poop today and all those sorts of things. I think it's an unrealistic expectation to think that your kids are actually going to do that. And so as parents, we really have to be proactive until they're old enough to really take ownership of things. And that's just, it's a burdensome reality.
Yeah, I just shared a screen. So this concept about hydration comes up in every specialty, the GI doc, etc. And then I do have a link that I shared about how much water children need, and it's astounding. 4 to 8-year-olds need 1.7 liters per day. So some tricks for that, honestly, we don't like juice. All pediatricians say no juice. There's no need for it. I have found that flavored water makes a difference. Maybe letting your children make their flavored water at night that they're going to take to school. There's these brands like Hint, even Nestle has it. It's literally just tropical twist water in it. There's nothing in it besides natural flavors and water. And they like the feeling of having a juice box, which I hate for the environment, but it makes it like a special treat. So you really have to be creative. You can do some herbal teas and then put them in some of the water and make it cold. But you really have to be creative, and then ask your children if they don't want to drink, say, okay, but you got to listen to your body and explain to them, show them what their stool looks like and show them the Bristol stool chart and say, now, look, what do you think? Do you think you need to be drinking more water? So you give them some ownership in it, because my son will refuse because, Mommy, remember, I'm going to listen to my body. And the next day he's like, my body told me I need to drink more. And so he was, but it was his decision, and it was less of a fight. But it is so hard. I don't think there's any way to understand why it's so hard to get kids to drink water. I tell them,
I started with my kids. I started my kids when they were younger, and with their water cups I used to always put a little bit of prune juice in their water cup, and they got used to that flavor. And then I would just kind of change the amount. So if their stool was just getting a little bit harder, I'd go a little bit more prune juice, a little less water. And if their stool was too loose, I'd go less prune juice, more water. So I kind of titrated it in a way so that they were trying to be hydrated. They got used to those types of flavors early on, and then it was managing their constipation a little bit better, and it was just part of their routine. But even to date, it's really hard to keep my kids hydrated. It's very, very hard, and we are on top of our kids, like you wouldn't imagine. But sometimes a little flavor goes a long way. But I absolutely agree, water is the best. Low sugar beverages or no sugar beverages, I should say, are ideal. We always try to stay away from like the apple juices and the fruit punches and those types of flavored drinks, because they just have so much sugar and it's terrible. But a little flavor goes a long way.
I'm going to put up the Bristol stool chart, which anyone can look up. And that's something that I think is great.
Yeah.
I took this one up right, Wikipedia.
It's funny. One of my kids is a little snobby with water. She likes orange flavored Perrier.
Oh my gosh! As parents, anything you can do to get them to drink it, right? It's just like when push comes to shove. Fine,
She
fine, you
runs
get it.
around saying, "Dada, Perrier, Perrier's." Okay, honey.
Oh, I'm buying $1.25 bottles of Hint, Hint, Hint water. And it tastes great, but I'm like, why can't we just put some watermelon juice, in our water and make our
You
own?
should buy stock in that. That's what you should do.
We should. That is like a penny to make and $1.25 to buy.
Dada Perrier. I mean, if I had a nickel for every time I heard that.
I do want to bring up this opportune moment, a brilliant suggestion you had for my little babies that were constipated.
Yeah.
It's so simple, and I've shared it with the GI docs and other people. Or maybe I think it was you that told me to use Pedialyte instead of water
Yes.
So what people need to know about babies, they don't have they don't have a functioning kidney the way big kids do, and so and I really wish the AAP did more on education. In my experience, there's been every year or so a pediatric death, an infant death from water intoxication. And when your child has a virus, you can't just give them plain water. So when we use it as a treatment for constipation, I always feel like, oh, it's not ideal. But yet Pedialyte, which you suggested, is a great replacement for water when you need to get more fluid in the bowels to get them more regular.
So, constipation in young children, especially in the first few months of life, is very difficult to even diagnose. Because we'll accept a child, not stooling daily or having some low quality stools. And we don't typically see this in breastfed children. We'll see this more in formula fed children, obviously, but you can still have some constipation. So the caveat is if a child is eating well, putting on weight, not fussy, and is just, happy as a clam, then you don't necessarily have to focus on the constipation as much. But if they haven't had a bowel movement in 3 or 4 days, they're fussy, their oral intake is not good, they're not feeding as well, you don't really want to sit on that too long. And so a good approach is to kind of get them going. What you could do is, believe it or not, a little suppository or half a little glycerin suppository can help just to kind of get them going. But as a long-term solution to constipation, if it's a thing, is a little bit of Pedialyte in between feeds. And so I always tell my families, because it's very safe and it's more physiologic, but I always tell them it should never replace calories. So you have to make sure they're getting their bottles or, breastfeeding as often at regular times, meeting their weight, requirements as they grow. So making sure it never replaces calories, but just supplements hydration. So in between feeds, you can supplement with an ounce, half an ounce to an ounce, or depending on how old they're, 2 ounces or 3 ounces, but it should never replace calories is the message I wanted to make sure is abundantly clear until they're old enough to start until they're on solid foods. And then you can start to gradually come in with some water and, what we did. So we started with when our child we thought was a little constipated, we did some Pedialyte, and then they were used to that taste. So we did Pedialyte with a little bit of prune juice and water, and then we cut out the Pedialyte and I've just done prune juice and water. And that's worked very well for us to help manage constipation, lifelong for our kids.
I have a patient who has like a 10-month-old who's become really picky and she wants to introduce more vegetables. And she realized if she blends it into a smoothie, she could give it to him. And I said, no, we don't put anything in the bottle besides milk until once in a while we'll do what you suggested. But from besides a host of problems that could cause, the kidneys, at what point are the kidneys able to regulate the electrolytes and solutes in the way they should? I understood it was close to 2 years of age, but maybe you could speak to
earlier.
that.
Yeah, you can earlier. I mean, closer to be honest with you, closer to 6 to 9 months, around there, you can be a little bit more liberal. Certainly in the first few months of life, absolutely not. The general rule is if they're on a solid diet, if they're eating solid food, or you're starting to introduce whole food, obviously blended or pureed, but if they're starting to have more food, initially, typically you'll do some breast milk with the food, and then you can start to taper off. And it really just depends on the child, but closer to 9 months or so, you can start to introduce it a little bit more, comfortably. But like you said, it can't be in large volumes, obviously.
Yeah, and we find, you get a lot more. I did with, I don't know if you know Dr. Alini. He did a talk, one of the first talks with me about how much you lose by blending your fruits and vegetables.
Yeah.
You're taking away from so much of the prebiotic, and then you lose the heart health of the fiber, and there's just so much to be said for not blending foods when you don't need to.
Yeah, no, absolutely. I mean, early on when they're like 6 and 7 months and you're introducing food, what we typically did is we just mashed it up gently, and sometimes if the texture wasn't good, we'd introduce a little bit of some sort of breast milk or formula, or even just a drop or two of water, just to make the consistency a little bit better. And that was, a way of safely introducing those things, and then also making it palatable for them, because ultimately you want them to get those calories in. But that's kind of that's all anecdotal. I defer to your expertise for this.
Yeah, it's all complicated. Believe it or not, something this simple is complicated, because you want to make sure the kid's not falling off their growth curve, and how they start to form their occupational, we call it occupational therapy, when they aren't doing chewing, etc. So we would want to look at that as a whole picture. Anyways, we've spent 40 minutes, 30 some minutes on our first question. And just to summarize, your pediatrician will probably, but it was the most important, I think, far as the general public is concerned. Your pediatrician will usually refer to a urologist for those factors that we discussed that would cause you to get an ultrasound. That would mean you had a fever, so maybe we call it pyelonephritis, or kidneys were infected, or you have recurrent documented urinary tract infections.
That's right. From an appropriately collected urine specimen, yes.
Okay.
And then get an ultrasound. If there's anything abnormal on the ultrasound, consider a VCUG. If you're not sure, we're always happy to see these kids and help manage that, or even give us a call, and we'll help you. We'll take care of our kids together and decide what the next step is, if it warrants a VCUG, or just have them referred over. But it's never wrong to approach it in that stepwise fashion. And then look at some of those key things that we know have been really well documented to increase the risk of urinary tract infections: hydration, bladder dysfunction, bowel dysfunction, perineal hygiene, and then taking all those things together will give you the best chance at reducing the risk.
Okay, yeah, and that's what parents can do. We just talked about the hydration, and
yes.
So I'm skipping through that second question because we did talk about it. So what do parents need to know about bedwetting and daytime incontinence? And in this question, I think what's most yield for the public is, at what age is it actually pathologic? And, are there hereditary causes for it that make it okay? What can you...
So, yeah, we see a significant proportion of kids. So, every day in one of my clinics, I'll see about 5 or 6 children with, we call it nocturnal euresis, or nighttime accidents. And it could be nighttime, daytime accidents. Not to sound too redundant, but what it does is those are the very similar risk factors for urinary tract infections as well. That bladder and bowel health, it kind of goes together. And there's 2 really simple rules that we have for avoiding urinary tract infections. And the first one is, the bladder never leaks if the bladder is empty, which kind of sounds silly, right? But it's true. The bladder will not leak if the bladder is empty. So you need to empty the bladder regularly, as often as possible. And that happens at nighttime. So make sure at nighttime, try to keep the bladder empty as much as possible. So make sure your kids urinate, and oftentimes double void, before they go to sleep, because some kids carry a little bit of residual. So get them to urinate, and then get them to wash their hands, brush their teeth, say goodnight to everybody, come back and urinate one more time, even if they don't feel like it. So double voiding helps. And then also cutting the fluid down 2 to 3 hours before they go to sleep. Now, I don't like children to suffer, right? If they're really thirsty, they can have a sip or 2 of water, but we don't want them to drink large amounts of water in the evening. So big glasses of water, or consume a lot of food that is rich in water. I saw this one family repeatedly, and we weren't making any steps, and they were promising that they cut the fluid down, and the child was double voiding and doing all these things. And the reality, he would consume a large watermelon before he went to bed. So water exists in food, and so it's really important to
He's
cut down on
smart. His body was thirsty, and he found a way to get that fluid.
He got it in. But I don't want him to suffer, so a sip or two of water is helpful. So you want to keep the bladder as empty as possible at nighttime. Then the bladder is not going to leak if the bladder can hold an amount that's appropriate for your age and for your size. And that's kind of like the second rule. So you want to make sure that, so one of the key things, and again, this leads back to constipation. We all know, especially in women, it's evident, the anus, like the poop hole where the poop comes out, and then the pee hole, the urethral meatus, are right next to each other. The place in the body where stool is stored in the rectum and where urine is stored in the bladder are right beside each other. They're literally right on top of each other. And so if you have a lot of stool, so even if your child is stooling every day, but if there is a significant stool burden, what ends up happening is that stool takes up space in the pelvis and it compresses the bladder to some degree. So the best example I can think of is a pregnant female, late in pregnancy in the third trimester. If you ask her how often she pees or how she urinates, she'll say, I pee frequently and I pee very little. And that happens when there's a significant stool burden or if the stool is hard. What ends up happening is it pushes on the bladder and it gives us the sensation of having to urinate, even when the bladder is not that full. So the bladder can't hold an amount that's appropriate for our age and for our size because something from the outside is pushing on it. So when you clear out the rectum, kids tend to do better, especially when it comes to being dry at night. During the daytime, often, they'll have those signals that they have to pee and they'll be able to hold it and then go to the restroom. But at nighttime, that conscious ability to, hold your pee, to run to the bathroom isn't there. And some of our kids ask our parents, some of them are just very deep sleepers and they will just have the sensation of having to urinate even when the bladder is not that full, and then they'll just wet the bed. And so, making sure we have a good bowel movement every day is critical.
As a pediatrician, the first thing I think of when I hear about this bedwetting issue is I look at their tonsils and adenoids and see how deep sleep they're getting. Yeah. Because the way the brain works is it needs its restorative sleep. And if you're constantly not getting to that deep sleep, when you do it, it hits hard. Mm-hmm. So I always check that first. Is that something you actually catch in your office, that they're having bedwetting because they have some obstructive sleep apnea?
So very, very good point, because there has been some evidence to show some nocturnal euresis, bedwetting. It has been linked to weight and obstructive sleep apnea, which kind of go hand in hand in our kids. And so there are some close connections with that, and that is something that we do talk about. But it is really important to appreciate that even if you sleep for a good stretch of time, so 7, 8, 9, 10 hours, you're not drinking at night. So it's not as if your body's still producing lots of urine, because you're relatively on the dehydrated side. Not truly dehydrated, but relatively dehydrated. That's why when most people wake up in the morning, they find the pee is a little bit yellow and their bladder's full, because that's an accumulation of a lesser urine output over a longer period of time. So as long as they're not waking up to drink large volumes at night, or they're not consuming large volumes in the middle of the night, they should be able to go a pretty long stretch without wetting the bed, as long as their bladder can hold an amount that's appropriate for their age and for their size. So it's funny, I see lots of kids with bedwetting issues, and the vast majority of them will get better if they just cycle the bladder normally during the day, treat constipation, make sure they cut the fluid down in the evening tremendously, double void before they go to sleep, and really just kind of clear out the rectum as best they can by being on a stool softener. And the vast majority of kids will just get better. Now, the real reason people need to come and see me is because in a very small percentage of people, there's actually an underlying medical issue. And I tell my families, hey, listen, I'll never abandon you. We'll figure it out. But the vast majority of kids get better if you just do all those basic things. And you can employ things like bedwetting alarms, which have lots of evidence, for them. And so basically, as long as you're employing some of those, most kids will get better. It's only for a small percentage of kids that I need to see where there's some sort of underlying neurological issue. They need some sort of test, they need a bladder treatment, or they need some medication that I need to organize. And it could be related to some bladder overactivity. It could be related to something we call spinal dysraphism. For example, there's maybe a tethered cord or some sort of spinal issue. They may need some biofeedback or some other treatments, but there's a long list of things that I work through. But the vast majority of kids will get better if we just work on all those basic bladder and bowel issues that we discussed. Those will almost always get better. In a very small segment of that population, I really need to see to figure out what the problem is. I actually have a message. It's like a 10-minute message. It's an audio recording. I'll either email it to my family members or I'll airdrop it to their phones. And it basically has all these instructions on it. And I encourage them to just
I think I got it years ago. Yeah.
Yeah, I've been doing it for years.
It was a voice text. It was great. Yeah.
Yeah. I just said, have my voice lull you to sleep every night.
I do. I did recently read about, this was not recent, this was years ago, about the whole mechanism of the sleep bedwetting alarms.
Yes.
Because they're so simple and they're advertised everywhere. Do they really work? Well, from what I read, it's simple and true, and it retrains the brain in alerting your brain before you go, and then you start to connect the stimuli, and then you actually can do it on your own.
Yes. Yeah, they're highly effective.
Yeah, very effective. It just retrains the brain. And so I was going to ask if you encourage families to start there.
So I actually start with, my approach is kind of graded. So like least disruptive for everybody to more disruptive, because sometimes what families will, complain about is their kids are such deep sleepers. Everybody wakes up except the kid, except their child. So it is very loud. It is very loud and it is very bothersome. But along with those basic things that we just touched upon, I'll generally recommend the bedwetting alarm to try it. And I always tell families, if they've tried something in the past, it doesn't necessarily mean that it won't work again in the future. It just depends on how ready the child is and really how compliant they were with all those things. Because just like what we talked about, urinary tract infections, it's very multifactorial. So it's never like one or two things, like they drink a lot of fluid at night. It has to do with many issues, many variables that together are additive to give you to increase your risk of having an accident. So if you do some of the things that we talk about, you'll probably get a little bit better. If you do none of the things we talked about, it's unrealistic to expect anything is going to change. If you do everything we've talked about consistently, then you give yourself the best chance of being dry every night.
And what % of the patients do you see have a parent with this problem and just naturally fixed itself when they were 7, 8, 9, 10?
Yeah, so it's actually even older than that it kind of spontaneously goes away. So I even see some kids in my clinic that are 14, 15, 16 years old, which is very bothersome to families and very disruptive to kids. And there's a lot of social issues associated with it. So it's really important to look at those social issues as well, which I'll sometimes spend a lot of time on. And we've picked up a lot of scary things with just kids all of a sudden having bedwetting, some like unsafe home environments at the home. So I'd be remiss if I just didn't kind of talk about that. But the vast majority of kids, it does improve by about 15% per year in these kids, and up to honestly 15 years old. So a significant proportion of kids, it'll go away by about 10 to 12 years old. Most of them, the vast majority sooner than that, just like you alluded to. But even there's a significant proportion in some studies, like 5%, 5 to 10%, which it could still be to some degree some accidents by older, early teenage years. But it almost always goes away unless there's an underlying medical issue, which is what I kind of talked about earlier.
And what age would you say is average for children to be dry at night?
It's funny. I don't like to put a number on that one because it's very hard. Yes. It's a bit of a moving target.
So variable in my practice.
It's the same question. It's the same question that I get with phimosis, right? Like the tight foreskin. So when should I be able to retract my child's foreskin and clean the head of the penis in an uncircumcised? And we have a lot of uncircumcised kids in our practice. And it's kind of the same question. It's, for bedwetting, if your child isn't bothered, they don't care. We've ruled out medical issues. They're not committed to doing anything we talk about. From a social perspective, if it's nobody ever died from wetting the bed, I don't say that in a cavalier way, but that's the reality of it. Once I rule out all the medical issues, but it's very hard to get an unmotivated child, right, who's not doing anything you recommend to get dry at night. there's
Right.
very little that myself or the parents can do for that to happen. So it's really important to get the kids to have some skin in the game and to really understand that it's unrealistic to expect anything to change unless they kind of do all the things we talked about. And again, I'm not trying to sound insensitive or cavalier, but I could teach a monkey to be dry at night, right?
Mm-hmm.
And we teach our dogs to go out and pee and poop outside, right? We can, so a lot of it is behavior related. So as long as I kind of say this in a very gentle way, I'm not interested in really, in one's intention on this specific subject. You can try your best. I mean, you just have to get your child to do what's required, and most of them will get dry. And I tell parents, you know your kid better than anybody, and so what's going to make them want to get on board. But if they don't care, it's very hard. But things like tablets and phones, those are privileges. They're not rights. So sometimes we'll use those things to incentivize children. So more screen time or phone time or whatnot, or treats, sticker boards, like you said. Doesn't work for older kids, but you get more with a carrot than you get with a stick. So that's something from my wife. And so you just have to really incentivize your kids, and they need to be highly motivated. Otherwise, if you don't get them to do what's required, it's unrealistic to expect that anything's going to change.
And it is one of those things we just do not want to punish for.
Correct.
Or shame, but just talk through.
Absolutely.
Talk through reasonably.
And they really need to be motivated themselves. They need to really understand. They need to be motivated. They want to have to get dry, because we have some kids that just don't care, and it's very hard to have any meaningful progress with that.
I think the point is that you can see a 2-year-old dry all night, and that's going to vary. You're going to have some kids at 7 who finally become dry at night, and then clearly up until 15.
Yeah. So
there's no recipe, and that is where we probably see more of the genetics too, right?
You can. Yeah. Lots of stories of I wet the bed till I was older, and so there's a little bit more. The problem is if it becomes more of an acceptance thing, it's the kind of a very similar story. I see families come into the office and they just say, "Oh, my child just always a little constipated. They've always been constipated."
Yes,
constipated.
Yes,
and the truth is well, they don't have to be constipated, and we can work on that, and we can get them to a point where we, are really reinforcing good bladder and bowel health, and which is in everybody's benefit. It impacts everything we've talked about today already.
So yeah, let's move on to the next topic. This is just so great and high yield, but we're at 1 hour. Do you have some more time?
Yeah, I have a few minutes. No problem. I mean, I think I have a lot of questions about things like common urologic conditions, and I think it would be a great thing to just take a few minutes and talk about them.
Yeah, let's do that. That's our last point. What do they need to know about the undescended testes and
yes,
circumcision, hernia repair, and hypospadias? Whatever you feel comfortable talking about, we can.
Yeah, no, I mean, that's all I like to talk about.
Okay.
It sounds sad when I say it out loud, but it really is true.
Well, you're a surgeon. You like talking
about the foreskin's an interesting thing. The foreskin is very interesting because it is one of those things where there isn't enough data to suggest you need to circumcise all males. And so it's not something that we routinely recommend, but if it's something that families want, I'm happy to do it. So it's literally the only procedure that I do if families ask for it. You can come into my office and say, I want my son circumcised. We missed that window in the newborn period. I'm happy to do it for you. It's everything else absolutely needs to be medically indicated, right? But circumcision is one of those things. But beyond that, what's medical when it comes to circumcision? So, every male who has an intact foreskin, it's completely normal not to be able to retract it completely in the first few years of life. But just like bedwetting, there's no data to suggest, okay, at this specific age, this child needs to be able to pull their foreskin back and clean the head of the penis completely. But that does need to happen at some point. And so we start to talk about it when children are, 4 or 5 or 6 or 7 years old. Now, if a child has issues with the foreskin earlier, then that changes things, and then we start to address it a little bit sooner. But entirely normal for a child not to be able to pull the foreskin back, not to see the head of the penis in the first few years of life, and we call that physiologic phimosis. If they're having issues, there's some abnormalities with the foreskin, shaft skin, or the anatomy of the penis that I need to see them, and then we need to have a look at that and discuss what's required to fix that. And so generally the approach for foreskin is you start off with a steroid cream. You need to use it with gentle stretching, about, depending on the cream, anywhere from 2 to 4 times a day, and usually for at least a 6-week course. And typically, if you're going to see benefit, you'll see benefit. And treating the tight foreskin is generally successful. If you look at the literature, it's successful 70 to 95% of the time, depending on the studies you look at. So it's never normal for a male to have an uncircumcised penis in adolescence that you cannot retract, and that you cannot visualize the head of the penis and clean the head of the penis. So I can tell you for certain, early teenage years, around 9 or 10, 11, that's not normal. But there's a big gray zone. In the first few years, entirely normal. Just leave kids alone is really the message there. Unless they're having problems, urinary tract infections, skin infections that we call, melanocystitis, or infections of the head of the penis, which are pretty rare. And those are the kids that we need to see. When it comes
I do want to say, in my practice, since 2000, early 2000s, every a handful every year of the uncircumcised children have infection that you're not going to see, but we're going to treat it, and it's because that foreskin has debris and bacteria in it. So I do want to mention that, because at a young age, that's a reason to get circumcised. And then, are you saying the data is not clear? And I always thought there was increased risk of STDs and other.
So very good point. So there's a very good point. So let's just talk about each of those individually. So for example, for urinary tract infections, you basically have to circumcise 50 to 100 males to prevent one urinary tract infection. And so that's a lot of, from a number needed to treat perspective, it's kind of unnecessary. From an STI risk, things like HPV, for example, the foreskin acts as a reservoir for HPV. And we know that's been linked to cervical cancer and certain forms of, penile cancer. So very important, but we have a vaccine for that. There's some good studies in sub-Saharan African males that prevent HIV/AIDS, but our population is not sub-Saharan African males. And so that's not necessarily, that would have been helpful in the 80s and 90s when HIV and AIDS initially started, but that's not modern medicine now. It doesn't really apply to that. But again, having said that, nobody removes more foreskin than I do. I can almost guarantee it. And it is one of those conditions that if parents want it done, I'm happy to do it for them. But I generally get 2 kinds of families. One family knows they want it done and they miss that window in the newborn period. And then one family wants to know if it's medically necessary. And it really is my duty to give them the best data on that. And I give a long talk. It's like 45 minutes or an hour, literally just on circumcisions and foreskin. And I have this big chart about what are the issues with foreskin, risks and complications of having foreskin, not having foreskin, and all the issues like, for example, urinary tract infections, HPV risk, HIV risk, all that sort of, all those variables. And there isn't, I must say, even though I remove a tremendous amount of foreskin, there isn't overwhelming evidence to say we should be routinely circumcising all our males, but there is definite benefit, as you pointed out. There is benefit to doing it.
Okay.
Yeah. And that's basically it for on the foreskin. That's the skinny on foreskin. So
I will mention that we see quite a bit before you see it. So we see a terrible amount of headache and complications and return visits for redness and cellulitis around the glands and blah, blah, blah. So, but it's good for me to hear from your perspective that those can be treated. It's just terrible to have to do antibiotics oral on a baby, but we'll do it.
Absolutely.
So, and you mentioned the HPV.
Yeah, if there are issues,
there are vaccines for. That there's vaccines for some of these things, but I tend to see the same people are resistant to circumcision. There's kind of a distrust in the medical community, and they're a little bit less apt to also vaccinate at times. Some, not all. I mean, it's definitely not a direct correlation by any means, but that is something to consider too, that they're not going to possibly be protected from some of these STDs because they will refuse the vaccines as well.
Absolutely. No, you're absolutely right. Point well taken. I mean, there is probably also some bias, and by the time I see these kids, they've already had quite a bit of issues. But again, to your point, if they are having problems, then a circumcision is warranted. But the amount of kids that end up having problems in the general population, then again, to do circumcisions for for a variety of reasons, you have to do a lot of circumcisions to prevent each of those issues, like urinary tract infections, HPV infections, melanopostitis, that sort of thing. But you're absolutely right. I mean, those issues do arise, and we need to be cognizant of them, and then that circumcision will help with those. Absolutely.
I think the first time parents don't realize what they're going to be managing in the first couple years.
Yeah.
When they don't circumcise. So it's more for that perspective. I think when they're on their second and third, they're like, they know what they're managing. Just
Absolutely.
bath time and debris, etc. Nothing serious. Nothing on the level of needing your help.
Having said that, I mean, there are some days I have these circumcision days where I will honestly do like 15 in the morning. I mean, it's just a lot, but
yeah,
just helping kind of work through those, navigate those waters are sometimes a little bit difficult.
And then do you want to speak about any of the other topics that you treat?
Sure. Just very briefly, I can just a minute or two. I mean, undescended testicles, typically all testicles need to be down in the scrotum, and they need to be down in the scrotum by about 6 months of life, corrected for gestation. And if they're not down by 6 months of life in a good location in the scrotum by about 6 months of gestation, definite referral to a pediatric urologist to address it. So if you can palpate it or not palpate it, like it's not there at all, regardless, needs to be sent to a pediatric urologist. The role for ultrasound in primary undescended testicles.
I need to interrupt you. I'm sorry.
Yeah.
What about retractile, though? They come down, but then they'll go back up.
Yeah, so that's a subset of patients with retractile testicles. The problem is when we examine children, typically what happens is they move up and down a normal cremasteric reflex. And typically what ends up happening is you don't see them when they're in the diaper or when they're in their children's clothes. So most of the time, if the physical exam is unclear, you should also refer them over to the pediatric urologist. And then, we'll examine them and talk to the family, teach the family to examine. If there's any issues with testicles spending most of their time in the scrotum, then certainly surgery is indicated. And that's
so
something
at 6 months, you want the testes most of the time down, even retractile.
I don't want them down. They need to be down.
No, but when they're easily milkable back down into the testicle,
yes,
you'll want them in your office.
If you can get them down into a nice dependent location in the scrotum, then it's unlikely that it's a truly undescended testicle. Retractile testicles don't require surgery. All I'm saying is sometimes the physical exam is not as clear. There's a lot of gray. So if there is any doubt, you can send them over, and then we'll happily see them. But what I was about to say is don't get an ultrasound. We published some studies. Back in 2013, 14 in the Journal of Pediatrics. In pediatrics, looking at the role of ultrasound in primary undescended testicles. So otherwise healthy normal child with an undescended testicle. And the ultrasound was wrong 50% of the time. It's almost like flipping a coin. So we still see quite a bit of kids that have had ultrasounds for undescended testicles in our office, and it doesn't change the management. It's usually based on the physical exam. And so that's what's important to appreciate. So they need to be down by about 6 months of life. And if not, then surgery should be done in the next 6 months to a year, by about a year and a half of life. And those are the current guidelines from the American Urologic Association.
Got it.
And hernias, which is basically, we use the word hernia, but it's not a true hernia. That's when you have some fluid in the scrotum. We call that a hydrocele. And if it communicates, when the scrotum gets bigger and smaller, sometimes that suggests that there is this persistent opening that didn't close, that has to do with the normal descent of the testicle into the scrotum. And so basically what happens is most of those close by about 2 years of life, 18 months to 2 years of life. If they haven't, then they're probably not going to, and that's the time we need to see these kids, because that's when we would really fix it. And so that's the kind of the info on a communicating hydrocele, which we see lots of. When it comes to testicles, I mean, we should all be telling our patients this. They should all know about testicular torsion and an acute scrotum, which basically means sudden pain in a testicle that lasts more than a few minutes, is what I just tell them, is always an emergency. And it just needs to be referred to a pediatric center, so like a freestanding pediatric hospital. They shouldn't really go to urgent care. They shouldn't go to an adult hospital that sees kids. I mean, even a pediatrician's office is not the right place. It needs to go to a hospital like Chalk or Miller Children's, a place where there are pediatric urologists that can do the procedure. Because if you go anywhere else in the county, they're going to want to transfer you to our hospital, and it just takes a long time. And you need to really fix the twist in the testicle within a few hours. And if you don't fix it within a few hours, you can potentially start to have irreversible damage to the testicle and testicular loss. And so sudden pain in the testicle that lasts more than a few minutes is an emergency. Should go to the closest pediatric hospital to rule out a testicular torsion, or it could sometimes be an incarcerated hernia where something falls through that little hernia sac that I was just talking about and gets stuck.
I'm so glad you brought that up. I do talk in my well visits to all my male patients about this, because also I do recall having a patient after some trauma, and that's, is it correct to say that they get a higher risk of testicular torsion or incarceration after a traumatic event? So if the pain continues and is, it's been a few minutes since the child was injured in the testicle, you need to go to the emergency room, correct?
Just the truth is, especially if there is a trauma, because you could have damage to the testis that we need to fix. It also, you have undescended testicles are a slightly higher risk for trauma as well. So that whole constellation, just like you said, a good practice is pain in the testicle that persists if there's a significant injury, or if there's a torsion, or you're concerned for an incarcerated hernia. All of those things are emergencies, and you really need to present to the hospital. And it's just good practice. Again, you don't go to urgent care. You don't go to a pediatrician's office. You don't even go to an adult hospital that sees children. You go to a children's hospital.
I think it helps when you explain to parents that you're worried about the barrier of your immune system and the sperm losing fertility, because that their ears perk up and they're like, oh, okay. And so everyone's listening then, because we want them to be able to have children. Yes.
So that, that kind of blood testis barrier and developing anti-sperm antibodies is, I think, what you're alluding to. Yeah. A lot of that has been, I don't want to use the word debunked, but it's probably not as important as we think it is anymore.
Oh,
or
okay.
That we thought it was. So as long as we get to the hospital and we fix the torsion quickly, and especially with undescended testicles, because we know that testicles that remain high and outside of the scrotum don't grow, don't develop in a healthy, normal way. And so basically what ends up happening is their hormonal production and sperm production can be reduced. Now, thankfully, we have two testicles as males, or most men have two testicles. So even if you lose one or one doesn't work as well, most of the time we don't know about it because the other testicle makes up the difference. And so most of the time kids will do well regardless, but you do want to maximize the function of both testicles. So an undescended testicle that remains high for a long period of time doesn't work as well when it comes to sperm production and hormonal production. And then also has a higher malignancy rate, a cancer rate, than testicles that are in the scrotum. And so as males, we need to be teaching our or as pediatricians and physicians and parents, we need to be teaching our boys how to examine themselves regularly, especially as they get older, and making sure they know what's normal for them. And if they feel something abnormal, that it's something that they look at very carefully. Have them referred to somebody like me, or at least get an ultrasound to rule out something bad.
This talk is so full of such useful tips. I want to mention one last thing to see your perspective. I do, by the time they're getting into their late teens, I do teach men or boys, males, to examine themselves for testicular cancer, because there is truly a peak in the 20s. Is that correct?
Yeah, we even a little bit earlier as well. So we see that. So kind of like mid to late teens and early 20s, and then later on in life, testicular cancer has something we call a bimodal distribution. So it's like it peaks and then it peaks again, and then we kind of see it in the early part of our life, and then we see it later on in life in older males. And so lifelong, we should be, just like women should be examining their breasts, we should be examining our testicles. You get a colonoscopy at some point in your life, that should be the part of the exam, and it should start early on. And boys, young men should know what's healthy and normal for them.
I'm surprised sometimes when I see like a 20-year-old who hasn't ever been told that, or doesn't know what what I'm talking about. So I think it's important that all pediatricians talk about that in their teens.
Yeah, good for you. So, self-exam and testicular torsion, people don't really know much about that. And you'd be surprised. We just published a study looking at testicular torsion and delays to presenting to the hospital during COVID because everybody wanted to stay out of hospitals. And we found that there was a significant amount of delay in coming to hospital for a normal emergency. So that's just being published coming up next month in the Journal of Pediatric Urology. And so basically, people were delaying presenting to hospital. So there was a higher rate, we think, of testicular loss based on that. And so it's really important to understand that in that study, when we asked patients, have you ever heard of torsion before? Only like 3 or 4% of them, it was between 3 and 4% knew about it. And it's just one of those things that's not talked about either by doctors, parents, and very, very few people know about it. And every male should know about it. And then it's not even that. You need to know that you shouldn't go to just an adult hospital or urgent care. You need to go to a children's hospital, where the specialists are there, where they can do the procedure.
I think in plain terms, I just put it in the group of, if you have severe testicular pain, you tell mom right away. And I look at mom, look at the patient, and that's the end. That's the extent of my conversation, but maybe I could be telling them more about testicular torsion. Of course, everyone's limited in their time in the office. I have plenty of time, but I think I'm limited by their attention span because I'll go on. Look at us. We're already 15 minutes over the hour. So I will add anything you want to in the text box, as I've been trying to take some notes so you can look back. And if you have anything.
I do see the notes. Thank you.
Yeah, no, thank you. I learned a lot today. I'm sure my patients learned even more, and my fellow colleagues who take time to listen.
I just saw Hypospadias on the bottom, which is one of my favorite, one of my favorite things to treat.
Yes, and
I tell my parents,
done
I don't want to say that's my thing, but that's my thing. I tell my parents I'd come in on a Saturday and do it for free. I mean, that's just how I feel about it.
Well, it's an art, and I think people don't even know what it is. If you want to define it for them,
it's basically when the pee hole doesn't make it all the way to the tip of the penis, and so they pee a little bit lower. And sometimes it could be down at the scrotum, or it could be halfway up. Most of it is closer to the tip, and sometimes there's an associated bend or curvature and some skin issues. And it occurs like 1 in 200 to 1 in 300 live births here in California, but so pretty common, and because everybody gets excited and they want it fixed right away. And the reality of it is it's one of those conditions that typically will need to see and assess. Usually I establish care in the first few weeks of life just to say hi to the family. And then typically I'll see them back when they're about 6 months of life, 6 months to a year. And then that's when is a good time to fix it. And we'll talk about fixing it. And is it required to fix? Do we need to fix it? What are the cosmetic and functional issues? In my experience, most people already know if they want it fixed or not, but it is one of those things that if you have any questions at all, I'm always happy to spend some time on and talk about. And I have a big talk about hypospadias.
It wasn't the first time I consulted you, but it was one of the reasons I got to know you so well. You went above and beyond because you find them in the newborn period. And it's a very emotional time for parents to think that their child needs a surgery, and the amount of hand holding you did for a family of mine and the care, and you clearly were passionate about it. So it was a great time to get to know you. And
I tell my family
all my trust with all my patients.
It's funny. I tell my families two things, and I mean these wholeheartedly. I tell them I'm going to take care of your child just like they're mine, and I'll never do anything in your child that I won't do in mine. And then when it comes to penis surgery, and I mean this earnestly, I say nobody wants this thing to look nicer than me. And that's true.
The plastic surgeons put all their before and after noses and faces. It's too bad you really can't post your photos before and after.
I can't, but I do that for research, and it's all documented in the chart and that sort of thing. But,
so
in any event.
Well, thank you so much for all of your wisdom and the way you can make it real for all the families. And I would love to meet your wife one day. I'm so glad you have her to whisper in your ear that half of pediatric problems are behavioral. So she's probably helped.
My wife has been just a wonderful resource for me. And I mean, she's a wonderful mother and my best friend, but she's just been a tremendous resource for me in what I do. And, you know, Lauren's fantastic.
In fact, you were calling me back on your honeymoon, and I think you were sneaking away. Don't tell my wife. I was like, oh my God, honeymoon.
I always answer your phone, and it's just your phone call.
I think that was before I was even doing the concierge medicine, and I was like, oh my gosh, this man is serious. He's like me.
Well, half the time people call me before COVID, I was getting off a plane or something, and I said, well, I'm out of town, and I can help. I might not be able to see the child because I'm physically out of the city, but I'm more than happy to help you, and I can get one of my partners to see them if we need to do that quickly.
I think your next talk is going to be how to prevent burnout, because you have some secrets. You're 100% accessible to all of the county, attitude. And you're not, and you're still loving it. So
positive outlook. I was born an optimist, and I'm a man of faith, and all that has been serving me very well.
Wonderful. All right. Well, we'll circle back if there's any other questions that come up. And thank you so much for your time. You have a wonderful day.
Thank you so much. Thanks so much for this time. I really enjoyed it, and hopefully we'll do it again soon.
I would love it. All right. Okay. Bye-bye.